Good afternoon, ladies and gentlemen, and to friends who are joining us from the Netherlands, good morning. Welcome to the Healthcare Innovation Webinar, a collaborative webinar between the Singapore Institute of Technology, Kwong Hospital, and the Lean Management Institute, Netherlands. Today, we have speakers from both Singapore and Netherlands to share with all of you on innovative best practices in the pandemic world. This is the program for today's webinar. There will be a panel discussion at the end of the session, so at any point of time, feel free to click on the Q&A button on your Zoom control panel to post any questions you may have. Just a point to note, in the event of any technical glitch, don't panic, just close your Zoom program and rejoin the webinar again. To start off the session, may I invite Mr. Arthur Poh, Director of the National Centre of Excellence for Workplace Learning at Singapore Institute of Technology, for the opening address. Mr. Poh, please.
Thank you, Angelina. Good day, everyone. Good day, ladies and gentlemen. It is my pleasure to host today's Healthcare Innovation Webinar, jointly with Kwong Hospital, Singapore, and the Lean Management Institute of the Netherlands. We would like to welcome everybody, friends from Netherlands especially, and Singapore. Thank you for taking time out today to join us. As you know, COVID-19 virus has caused significant disruptions to the world economy. From aviation to healthcare, we have to adjust to a new way of living, working, and interacting with one another. For a university like ours, we are not spared too. Learning moved from the lecture theatres to online, and our administrative staff worked from home, just like today. What many had taken for granted suddenly changed, like well-stocked supermarkets, which we had shelves emptied by shoppers who went on panic buying. The food supply chain was badly disrupted as farms could not harvest their crops and had them transported to their customers. Disruptions, both real and sudden disruptions, turned all our lives around. To be honest, disruptions happened even before COVID-19 landed on our shores. There were pressures on organizations to adapt and adopt new technologies. Robotics, artificial intelligence, and machine learning were buzzwords for many years. But COVID-19 expedited the need to adopt these technologies very quickly. At my university, we quickly realized that one of the more effective ways in managing a volatile state of affairs is through collaboration with very good partners. More than ever, we need strong partners like Kwong Hospital and the Lean Management Institute of the Netherlands. Under the leadership of Chief Executive Officer Dr. Chung, who is here with us today, Kwong Hospital, Singapore has worked with my university to develop skills in the community care sector. I'm grateful that Dr. has agreed to share some of the innovation within his hospital and how the collaboration with SIT has helped to support Kwong Hospital's efforts in deepening the skills within the hospital and beyond through workplace learning. We are pleased to also have our friends from Netherlands, Mr. René Arnold, the CEO of Lean Management Institute, with us today as well. René is our good friend. René's Lean Institute is at the forefront of lean practice and research. Our partnership with LMI goes a long way. Over the course of 5 years, René and his staff have supported my team and many Singapore work improvement projects in healthcare and transport engineering. Some months back, during the heat of the pandemic, I shared with René it would be a good idea to have both countries come together to share our learning experiences in dealing with this pandemic. I'm glad he willingly accepted my challenge, and it is our privilege to be introduced to two speakers today. I'm happy to introduce you to Mr. Kjeld from Erasmus University's Medical Center, and Mr. Ham Nguyen from UMC Expert. They have been working in close partnership with LMI to improve processes and drive innovation in Netherlands healthcare centers. I hope you will benefit from their sharing. SIT looks forward to forging closer bonds and meaningful collaborations with our partners in the healthcare sector. I also invited Dr. Genedine Lim from our academic staff to share how we train our nursing students in light of the current challenges. Professor Genedine has deep and extensive experience dealing with the pandemic, having been involved in our response to the SARS crisis in 2003. We hope you will find today's webinar meaningful. Please feel free to contact us at the Singapore Institute of Technology should you have collaboration opportunities. I look forward to the opportunity to work together in the future. I wish everyone a fruitful time ahead and see you at the panel discussion later. Thank you.
Thank you, Mr. Poh. It is now my pleasure to introduce our first speaker, Dr. Chung, the Chief Executive Officer of Kwong Shiu Hospital. The hospital has recently completed its major redevelopment to transform into a community healthcare hub. The hospital has now doubled both its inpatient and outpatient capacities. It is now moving towards building a regional community healthcare system. A medical doctor by training, Dr. also has a master's in business administration. He has held several leadership appointments in the public service, VWOs, and the healthcare sector, such as restructured hospitals and healthcare institutions. He has a personal interest in the development of community care services. Today, Dr. will be sharing with us on Kwong Shiu Hospital's efforts in accelerating digitalization and automation in the new normal. Dr. Please.
Very good morning and good afternoon, depending where you are. I glanced through the participants, and among them, actually, many are close friends. I must first apologize that this is the first time I'm making a presentation in this format, so I find it a bit awkward, but nevertheless, I will do what I can. So for today's session, my focus is in terms of digitalization and automation, based on what we have experienced in Kwong Shiu Hospital. And in terms of what I'm going to cover, basically I'll provide a little bit of the context and dive into some reality check, and then using a bit of a technology roadmap to give everyone a sharing of what we have done in Kwong Shiu Hospital. But I think it's important that I put a caveat first. The caveat is that this whole discussion that I have today more or less focused mainly on nursing home in particular. First, I want to draw to everyone's attention. In fact, even for the locals, many may not be aware. If you look at the number of beds allocated to acute hospital, comm hall, and nursing home, actually in the 2000 period, there was actually more acute hospital and community hospital beds than nursing home. This may come strange to even for the overseas participants, and many in Singapore may or may not actually know. But with the aging population, the government has turned. If you look at these busy slides, I just need you to draw attention to 2019. We have definitely have more nursing home beds than the acute hospital and comm hall. And looking at the trend and towards this decade, I believe we'll probably have a scenario by the end of the decade about double the number of acute hospital and comm hall beds. What am I trying to derive here is that for the acute hospital, their effort into use of technology and automation, doing all sort of design and lean management, they have already done that very early on, almost for about 2 decades. For us in the nursing home, we are only just starting. But yet, interestingly, as a collective pool, our inpatient residential base, we actually have already more than the acute hospital. So there's actually a lot of scope for us to work on. So this brings to the story of my hospital, Kwong Shiu Hospital. So we are actually part and parcel of the whole nursing home sector, where most of us, all of us, are increasing our bed capacity. So for us, I think the vision was more or less set by the Prime Minister, whereby the government decided to allow us to remain on a plot of land. The land is reduced in size, but our expectation is that we are supposed to do more. So throughout this, I think coming to 10th year since the decision was made in 2010, I think for us to grow, I think 2 key strategies was very clear. One is to build capacity and partnership. The other one is actually a gradual introduction of use of technology. Currently, we are at a stage of where we already have the community hub at our current ground. And the new NHG Kallang Polyclinic will be up later this year. And we are marching into building a regional community healthcare system, of course, together with Tan Tock Seng and Central Health. Let's dive into some context. I think when you look at these busy slides, if I were to ask everyone to eyeball, I think most of people would know the pictures on the left side are from the acute hospital, and the pictures on the right side are what we see in the nursing home. Very straightforward. In fact, about last year, just before the COVID, if you look at one of the picture on the left about the beds in acute hospital, they were even talking about guided beds that can move on their own. Whereas for us in nursing home, even recently, some of the nursing home may not even have enough budget to buy what we call the auto bed. We still have to manually crank the bed. And this still occur in Singapore as a nursing home. I think there are many factors present. I would like to put a caveat is that I'm in no position to comment on the restructured hospitals costing what they have as a budget. I presume they deserve every cent of it. But I just want to draw your attention for nursing home based on what we can gather. If you look at the development cost at this present moment, we're talking about 120K per bed. 7 years back, it's only 100K. And that's all we have per bed. And we're supposed to include buying kitchen sink and everything else that we can put into the nursing home. So not much to go by. In terms of IT technology expenditure, I'm not sure currently there's a study or anything. Most of the acute hospital, they are talking about 4% at least of expenditure. So there's a lot of scope for them to work on. But for nursing home, my understanding is actually much lower. So we are on a lower expenditure, but yet even at a lower cost in terms of expenditure. So basically at the end, what I'm trying to say is we have very little to go by if we want to do anything in technology and IT. And in fact, I think recently NCSS has done a review on the IT aspects of things. I think the preliminary finding is that there is a great shortage of IT manpower resources, especially in the social service sector or in the community healthcare sector. Depending who you are, where you are, and what context you come from, I think these are classical textbook reasoning for people who give for not giving nursing home too much resources to go into technology and IT. That's on the left side. And then for us, as a nursing home and as a sector, we will of course have to justify where we are. I think the scenario over the last decade, I think have tilted a little bit to the right side. I think increasingly the size in a nursing home in Singapore, I'm not sure in Netherlands what other countries experience, which tend to be a bit smaller. Our nursing home are now growing bigger. We're talking of a size of 400, 500 bed nursing home. And in fact, these are fairly big size operation. So I think there are indeed more reason and scope for it. Of course, my most prevailing reason is that collectively, as a sector, we actually have so much more beds than the acute hospital. So why can't we have more IT technology that is put into deployment? COVID definitely, in many sense, expedited whatever we want to introduce as a sector, the classical manpower, etc., etc. But I think one thing is important, which I hope we as a sector can more or less acknowledge, is that there are more resources available for us to tap. Not easy, but they are available. For Kwong Shiu Hospital, this is our textbook for whatever justification we want to put in terms of whether we want to do IT technology, introducing automation. And we cannot run away from mentioning some of these items listed on the left side. I will come back to this later on to just to walk back to see whether we have indeed achieved that. So this is the macro script. Of course, we need additional script to put on the table whenever we put things up for our board or for the government. I think one of the important things is also for each organization to draw their own technology roadmap. This is a very rudimentary, simple one. There are, of course, academics that have a better diagram than this. Nevertheless, it's good to have an organization have a grasp of where they are and what they want to add on, and then sort of schedule a plan of 3 year, 5 year where you put it on. The reason is very simple. We are at such a low level, we just cannot afford to put all the boxes in at one time. There are a few points I wanted to sort of highlight just to put into perspective, and this is also partly from our own experience and my experience elsewhere. Whenever we put in place things that are transactional processing, the classical computer science understanding is that we definitely get about 20% productivity. But actually, when you implement, it's sometimes not so straightforward for two big reasons. One reason is that if we do not review the process, that means existing processes, you are more or less automating or putting IT on unproductive process. So in the end, you're still land up with the same bureaucratic flow, etc., etc. The other one is interesting. The other one is that because you thought you're going to get productivity gain, you start to put more things into the system. Instead of a simple checklist of 3 points, you say, oh, since it's computerized, I've added another 20 more. So at the end, when you implement the whatever transaction process system, you realize, hey, I do not get back that 10 to 20%. I think this is something that we have to be mindful of, especially when we start the project. Of course, in the Kjeld Hospital, they are already gone into decision support system 7 years back. They are in the knowledge management and the AI. I think there's still some scope for nursing home to move into this area, but very often whenever we see these type of big words, the cost seems to frighten us. There may be benefit, but there are also scope that if it doesn't work well, it becomes a major problem. So for us, when we go into technology as well as automation, I think there are a few points that was always in our mind in Kwong Shiu. More or less, this is what my board expects. And I presume many of the funders that in the government, they also expect. That is, first, you must be very clear what you want to achieve. And you better have an idea of the current situation and probably start doing process optimization first before you put in any of the, especially the more expensive technology or automation. The other point that we learned is that the importance, especially for big project, to have a POC, a trial, whereby before you commit the full maybe 500K or 1 million, you actually trial it out first to make sure that it actually delivers what you want to do before you actually launch the full scale. And this has to be part and parcel of the RFP, because if the vendor do not know in the beginning, they may not put up a proposal. And of course, lastly, learning and sharing, which I think for Kwong Shiu was very important because we started out at the beginning. So of course, we're happy to have a partner SIT. And of course, in the last few years, we've been training our colleagues, nurses, frontline staff into lean management. And when we did the training through the CTI, we did not learn on our own because there were participants from the sector. And together we learn as a group, because I think it's important to get the culture in the nursing home, different departments. It is not possible always for the CEO or the director of nursing to be running all the project. It must be done by those colleagues at the ground. So we have the map that I mentioned. So for Kwong Shiu, besides writing the script, this is our map. This map will be updated almost every year for the last couple of years, where we'll tell the board, this is what we have, this is what we want to add, and this is what we need. So it's a more of a snapshot of items that we have put in place. Different colors, meaning some are already in, some are not in, some are coming or maybe coming forward. But it's important because we need to make sure all the systems are stackable and there's a sort of a backbone of understanding. More importantly, is also to preempt the board and also preempt our budgetary requirement. Interestingly, in the year where we are supposed to be very stressed out in the COVID, I'm happy to share that it was also the year that I managed to get the board to move our whole finance admin system into an ERP. I guess during the process of getting it through the board, we were very painfully seeing the current situation where we literally have the hard copy pushing around. In the beginning, we used to put on boxes where, because the colleagues are voting on split teams, they had to come back to work on different week to sign it. So we really truly experienced the what we call what if we have everything on the cloud, and we will have make things so easy for everybody. So actually we got the project ongoing last year. And we have actually started even working offline with the consultant. We more or less map out the workflow. In the next few months, we'll probably going on live and parallel run. And of course, for those who know what ERP, it literally automates most of the key elements. If not 100%, I think at least 80 to 90% paperless. So this is something we have put in during the COVID period. And probably if there's still COVID, we probably will have dragged the decision for maybe another year. So wait for another year, wait for another year. But I think COVID more or less make the board and management realize that we better press this through. So I'm happy that this is ongoing. So this will be something, what we call the financial admin system 2.0. The other important system which I want to put first credit to is our clinical system. I think the clinical system is a very major system for any healthcare organization for nursing home. And here I want to put a special thanks to the consortium work group where we are using a common platform. And we also want to give credit to Lian Foundation because they are the one that pushed this agenda and supported us, at least the startup capital. What I want to share is, in particular, is that there's no way for one nursing home to champion one application system for themselves. The cost will be very high and it's almost impossible to be able to engage any vendor to do anything. But because we are working as a consortium, we work together as a group and we have managed to work well with the vendor as well as the strong support of Lian Foundation. So the system has evolved. And more importantly, the consortium group has good vision. So we did not just land up with a nursing home system. In fact, with the same platform, we are ready to move into the new platform whereby the same look and feel will be incorporated not just for the inpatient, home care, as well as daycare. And this is almost like a wonder system because the current availability of other system is that we don't have such a system. The only system they have is either a clinical system standalone, or you have to just get off the shelf for others for home care as well as senior care. So as a consortium group, I think what is illustrated for nursing home, we probably cannot take big hairy project on our own. We probably have to find some platform to come together. And when we come together, we can achieve good things whereby we have such an elaborate system. So I think this is something that Kwong is very happy to be part and parcel of the consortium work group. Of course, the other element is to really put technology into place. Here, I want to just highlight one element because later I have a video. If you look at the picture on the left, this is what our busy day looks like. A group of people, of colleagues go out and get the food and then etc. We actually have to do a process review first. So one of the process review is look at the number of trolleys they have to push. How do we redesign the trolleys such that we don't have to buy so many robots? One robot can carry one trolley. So that type of work must be done upfront. Because if you follow what we have done in the past, I would have to buy so many robots just to fit the item. I'm going to show you a bit of a video. So Angela will be shooting on the video mode. Basically, is to give you an idea of what I see as a technology map that flows through from one point to the end, whereby the end is basically our nurses serving our patient. So the most important in nursing home is makan, food. So we have been always into this rotary walk for a long time. I've been sharing this, but I think today I can say that the Rotary Walk did provide productivity gain because we are operational for 2 years. We used to budget because of growth, double the number of staff because double the beds. But we were saying that with the walk, we don't need so many. And it holds true. In fact, we are able to maintain the number that we wanted, and we have got good productivity gain. This robot automated walk, of course, is not just about the walk doing the work, but it's also allow us to hire different colleagues because the walk does most of the heavy work. So even a colleague who is not a big feature can do the frying, so-called auto frying. The kitchen has been given a hotspot for Kwong Shiu in the sense that we just look at it. We do a lot of automation now about washing the dishes. We even have automated rice cooker coming on board, washing of rice, etc. So all in all, we try our best every year to add more automation into the. After that, of course, it's a transfer of food to the ward. And this is whereby we are fortunate the timing is right. The first generation of robotics is always based on the track, what we call the AGV, which doesn't allow us to do anything on existing ground. Very difficult. So we have to look for technology that's able to maneuver within existing narrow space, etc. So we managed to find one, and we went through a POC. The POC allows us to identify many things, and then also to affirm that we can deliver it. So for example, in this picture, you can see that the door needs to be open. For those who are in nursing home, you know you will never have a ward door that's open automatically. You have to manually do it. So all these are things that we learn. So when we reduce the number of staff in the ward, we also must help the ward. So the clinical system that we have was very good. Even now, our vital signs, we measure blood pressure, is automatically uploaded. So we experimented on wound management because we're going to have a chronic state, we're going to have more patients. So wound management has been very classically manual. We use a ruler to measure, etc., etc. There are many devices available nowadays. This one we work with MOHH, where there's an AI built into it. So we are more or less part and parcel of a consortium to get all the data in. In the end, the wound is not only properly captured into the system, but we also able to use the AI to predict the wound management. But I think what I wanted to highlight with this video is the importance of having a technology map to say that every aspects of it, we try to put things in place. But I wanted to highlight that it's not so straightforward. We must be very clear that the processes need to be improved first. So for example, just now I mentioned that if you were to go by a very simple automation, I would probably need more than 2 AMR. We probably need like 4 AMR, but because we also redesigned the trolley, now we just send one trolley to one ward. So that in itself has to be done upfront. And secondly is that for big items, I think it's important to put in an RFP, a POC. If the POC doesn't work, then we have to stop the project. So I think all in all, these are some elements that we have. We are still learning, a lot to learn from others and other nursing homes have. So fortunately for us, we have a good partnership at SIT, and this is whereby under the lead community care sector, whereby SkillsFuture also provided some funding for us. And we believe that in collaboration and partnership, Kwong, you have a lot of problems. We learn on our own, but we will never get the true knowledge if we don't do it together with the sector. So this particular project that we have, for instance, is one example where we hope to bring the sector together, where we learn together. More importantly is that through SSG, we actually provide the resources and make the training more affordable to the sector. And there's also consultants and trainers that will be guiding us. So one of our flagship that we started this year, very well participated. We have about unique organizations have joined in. So many of them has given a good thumbs up on the first run. And I think we'll be running more. And later on, I think there's something more for everybody to come in. But I hope the sector will see this as very important. Each one of us have many issues at hand. Each one of us have some solutions. But each one of us, if we were to go out on our own, the cost and the journey will be very tough. But if we come together, we are able to engage the problem together. We are able to share the cost together. We can do good things. So the INGOT consortium team of IT is a classical example. So for us in Kwong, fortunately, with the SSG and SIT, we are able to provide this platform. So hopefully all will come on board. So for us in Kwong, this is my script. Every year, this is the same script. And I have to convince the board, the funders, that we continue to do this. So far, I would say that we more or less check off. We are now able to have a community hub. We are now going to work closely with, even more closely with Tan Tock Seng as central health in the regional system. Manpower is interesting. We used to have a foreign staff about 57%. We are now able to recruit more local. We're down to 50%. And interestingly, the last record has shown that we have more than 70% with us for more than 5 years. So we have been tracking all these statistics because we have to justify all the reasons. And of course, at the end of the day, we are fortunate to have grants available. No matter what I say, at the end of the day, what is important will still be the people we serve. We hope that through all this, we can be more effective and efficient, and they will continue to stay healthy wherever they are, be it at home, be it in the nursing home. I think with this, I will end my session and pass it back to Angela. Thank you for your attention.
Thank you, Dr. Au, for sharing your valuable insights. Moving on to the second talk, we have Dr. Kjeld. With over 2 decades of experience in the healthcare industry, Dr. Kjeld specializes in lean healthcare, spearheading various projects in the area of quality and patient safety, introducing lean thinking and lean processes in the operating rooms. Dr. Kjeld is also an active research member in the Lean Healthcare Research Consortium of Stanford University in America. He has conducted intensive research into lean leadership and change management. He is currently appointed the director of Erasmus Medical Center in Netherlands. Today, Dr. Kjeld will be sharing with us on innovation and management during COVID-19 crisis in Europe. Without further ado, Dr. Kjeld, please.
So thank you, Dr. Angelina. I also want to give a special thanks to the members of the organizing committee of this healthcare innovation webinar, Singapore Institute of Technology, Kwong Shiu Hospital, and Lean Management Institute for giving me this opportunity to address you here today and to share some of our innovative best practices from the Netherlands. For the next 25 minutes, I will zoom in specifically on this topic, perspectives on innovation and management. On this picture, you see the hospital in Rotterdam, an academic medical center, Erasmus MC, it's called. It looks a little bit like Kwong Shiu Hospital, I think. Maybe the buildings are a little bit taller, but I look at the pictures of your hospital and I really love the scenery. So maybe we can share some things together. Firstly, let me introduce, say something about myself. I serve as a decisive leadership role to transform an academic healthcare setting into a high-performance center of excellence. I'm one of the business directors of Erasmus Medical Centers, one of the 7 academic medical centers in the Netherlands. An Erasmus Medical Center supports, stimulates and facilitates scientists and supporting staff in knowledge valorization. And we organize and implement learning and development programs and promote and develop leadership skills and behavior at individual contributor and management levels. So I'm humbled to say that Erasmus Medical Center is recognized as a leading innovator in healthcare in the Netherlands. So I want to address this day a few topics. And the first topic I will address is understanding the innovation imperative. Oh, I have to go back to one slide. Understanding the innovation imperative, previous slide. Here you are. There's a little bit delay, yes. Understanding the innovation imperative, organizing for innovation. I give you some examples from Erasmus Medical Center, and I also will elaborate briefly on fostering innovative behaviors. So first of all, what is innovation? Innovation is truly a confusing buzzword, which many people love to hate. Every business leader agrees that it is very important, but nobody can quite seem to agree on what it is actually, or what it means. It means different things to different people. If you ask Google for an innovation definition, it is less than helpful. coming up with over 300 million results with thousands of definitions. So I want to add one definition more. It's my definition. I think innovation is all about turning an idea into a solution that adds value from a customer perspective. So it's something new. You don't know what the outcome will be, but it has to improve quality and outcome and add value from a customer perspective. And that requires changes in the way we assess and incent individual and team behavior, implement processes, but more important, we have to foster collaboration. Otherwise, you cannot innovate. And that's challenging because we have daily pressure to deliver on short-term performance goals. And especially during a pandemic, COVID-19 pandemic, the pressure is much higher. So it's really challenging. And I think for many years, executives equated innovation with the development of new products. And I have a slide here, and that shows 10 types of innovation. It's a great book from Larry Keeley. I can recommend that book. He describes 10 types of innovation. And I wanted to show you this slide because when we think of innovation, most of the time, we think of development of new products. But as you can see, there are different kinds of innovations. And the problem with development of new products is that's your mindset, your perspective. Creating new products is only one way to innovate. And on its own, it provides the lowest return on investment and the least competitive advantage. All great innovations throughout history comprise some combinations of these 10 basic types. So it's not all about products. It can also be innovation on process. It can be about service. It can be about customer engagement. And you can use these 10 types to help your innovation efforts in many ways. It can be a diagnostic tool. Are we too much focused on products? It can help you analyze your competitive environment, and it can review gaps and potential opportunities for doing something different. So remember, there's not one type of innovation. If I think of innovation, most of the time I think of AI or big data. But innovation can also be about process, services, customer engagement, for example. If we look at the background of innovation, we see we have all different kinds of agendas, different sides, several cost drivers. For instance, aging population, increasing number of patients with chronic illness and diseases, rising costs of training staff, personalized care, and we see innovation in different fields, in diverse fields, technology, biopharmacy, business. So I think, and that's one of my key messages, innovation will change the way how healthcare organizations prevent, diagnose, monitor, and treat diseases. But then again, we have to ask ourselves the questions, how can we innovate? And what challenges are we facing? So, innovating thinking, like critical thinking, does not come natural to most people. That's one reason why innovation is so hard. The past 20-25 years of research in neuroscience and psychology, behavioral economics and education have demonstrated that we are highly efficient, fast, reflective thinkers who seek to confirm what we already know. As a result, we are cognitively blind to disconfirming data and challenging ideas. In addition, our thinking is limited by our tendency to rationalize information that contradicts our beliefs and by many cognitive biases. In a nutshell, When we are on autopilot, we are not critical or innovative thinkers. We are confirmation machines, so to speak. To innovate, people have to take their normal thinking to a much higher level. Most of us have to be taught how to do that. And our educational system and most work environments have taught us that good performance means avoiding failures and not making mistakes. And this is a big problem because failure is an unavoidable part of innovation experimentation. Innovation requires the willingness to fail and to learn. Plan, do, check, act. Plan, do, check, act. So, innovation, there are a lot of definitions. There's confusion about innovation. But how can we turn innovation from a wish into an action plan? I want to elaborate and say some things about it. This means that in order to innovate, we need to change our attitude towards failure and mistakes. I already mentioned it. Contrary to what many of us have been taught, avoiding failure is not a sign that we are smart. Being smart is not about knowing all the answers and performing flawlessly. Being smart is knowing what you don't know, prioritizing what you need to know, and being very good at finding the best evidence-based answer. Being smart requires you to become comfortable saying, I don't know, I don't have the answer to this problem right now. Innovation requires a different culture, a different mindset. And most organization environments won't help us overcome our fear of failure and build our innovative thinking skills. That's because most organizations exist to produce predictable, reliable, standardized results. And in those environments, mistakes and failures are most of the time bad. And that's a big problem. Want to innovate, you must simultaneously tolerate mistakes and insist on operational excellence. And many organizations, even our own hospital, struggle with implementing that dual mentality. In our organization, mistakes and failures have to be redefined as learning opportunities. Dr. Owl also mentioned it. Learning is important. But in many workplaces, people do not feel safe enough to dare to speak up. They don't necessarily feel that they can speak with candor up and down the organization. Can you tell your boss the truth about your process? So if you want to turn innovation from a wish into an action plan, that requires a different culture. And innovation outcomes will only be possible when our behavior, the behavior of leaders, the behavior of care professionals, nurses, doctors will change. So now I want to show you a few examples of our innovation best practices from my hospital last 2 years. So I can give you an idea what we did. And it's important to know it's not highly cost expensive innovation. These examples are examples from the working floor. Nurses had great ideas, so we went by their ideas and implement some innovation. Let me show you my examples. First of all, here you see on the left side of the picture, our daily practice issue. If you want to measure the fluid levels, the nurse had to get on her knees or lay down to measure the fluid levels on the left side. So we thought that's a problem, it's inconvenient, but maybe it's not healthy for the back of the nurse. So what we did, we use standardized tools. We used an iPad and a small camera, just a few euros. and now the nurse can stand up and measure the fluid levels. So it's a small ID. It started with the ID of the nurse, but you can see it don't have to be expensive, and it easy your work very much. Another example I can show you is from our child department. We used to use measuring tape on the left side, but that's a problem, especially during COVID-19, because how can you clean this kind of reusable measuring tape? How do you clean this measuring tape during COVID? So we came up with an idea. On the right side, it's more precise, and you don't have problems with cleaning. And also, this idea is just less than a cent to make. The next example, maybe you can relate to this if you are a nurse. It is an example on safety for staff. On the left side, this is the way we used to work. We use scissors, we use coins, we use all different kinds of tooling for cap removal of ampulla. But we had a lot of small accidents. It wasn't handy. It took too much time. So we developed a stainless steel dop whipper, it's called. It's easy to clean and a safe alternative. Another example is we had a problem with all kind of cutting incidents, breaking the glass ampulla. So we looked to that process. We worked this way for, I think, 30 years. And then a nurse said, can we develop something easy, not costly, to help us breaking the glass ampoule? So we came up with this happy breaks, and now 2,000 of these happy breaks are distributed in our hospital and used daily. And we see our cutting incidents from breaking glass ampoule reduced to 0. So that was a great innovation, I think. And this example, we call it a happy feet. Nurses, and I was a nurse for 5 years as well, registered nurse. I always used tape to fix things. So maybe you can relate to that. On the left side, we had to fix a gastric tube holder. We didn't have something like that, so we used tape, but when you remove it, it's sticky, it's unhygienic, it's difficult to change different tubes from different syringes. So we developed for a few cents, we call it the happy feet, a versatile from 2 to 50 milliliter syringe. Also, this idea came from nurses that were used to work with tape and fix things by themselves. And now we have much more easy, much more hygienic idea. And the last example I want to show you is about organizing cables. We had a lot of problems because these cables were all over the place on the bed. And when you detach the railing of the bed, some of the cables will get stuck between the bed and get damaged. So we had to fix the cables or repair the cables because it was dangerous when the cable was broken or the top layer was damaged. So one of the nurses, he's called Koos, and that's why this device called the Koos guard. This nurse, Koos, he sat down with his team members and said, can we think of something so we can organize the monitor cables? And using this cable clip is the perfect way to conceal bedside monitor cables. And because you can easily manipulate the cords, to where you want them to stay, so they don't get stuck anymore between the bed railing. So costs were reduced for replacement of cables, and just for a few cents. And we put the name of the nurse, Koos, on this device, the Coast Guard. And it's, I think, a really interesting example. Came from nurses, no expensive artificial intelligence, but day-to-day business and problems we would like to solve. So what do we have to do to foster an innovative culture? What does an innovation culture look like? I want to highlight one important thing. You have to encourage team, and you have to encourage cross-functional collaboration. So collaboration between nurses and doctors, between senators. So it's very, very important that you encourage teams and encourage cross-functional collaboration. And you need leadership. You need leadership to do that. And why? Why is leadership so important? In my opinion, because organizational leaders should be the main focus of training efforts, since they directly and dramatically influence the morale of the teams, the safety, the quality, the cost, the productivity, and provide a pipeline for future leaders. They build the foundation to innovate, for problem solving, for all improvement efforts within your hospital. And during the COVID crisis, we thought, oh, we have a crisis in our hospital, and we were very busy with it. Still, we are very busy fighting the COVID crisis in the Netherlands, in our hospital. But we already had a crisis in healthcare, and I call it the value crisis. We had already in healthcare a value crisis. And let me explain a little bit more. If you think about healthcare and the value, actually the value is declining. Because if you see value as quality divided by cost, here you see a chart with a blue line and a red line. And there's something about this chart. The cost increase goes much higher than the quality increase over years. And this was a study done by John Toussaint in 2012. We are now 10 years later, and you still see that the blue line is rising more rapidly than the red line on quality. And that's a problem, because if you show this chart to most managers, they will focus on cost instead of quality. And then you have maybe problems with your quality, and then that's a big problem for the incentives. So we have a problem, a value crisis, and one of my learning keys will be a focus on the quality, not only on the cost. Cost is only a result from good quality. The second problem that gives us a value crisis is we have old rusty processes. Here's a picture from it. Old processes are not a problem, but rusty processes are a problem. The third problem I want to mention, why I think we have a value crisis, is we have difficulties with learning. You see here three blocks, blue blocks. In the middle, you see the words strategy and techniques. But you can also add the way you used to work. And if you have good results, then you continue your way of work, your strategy, your technique, your way of working. But if you have bad results, most of the time in our organizations, we throw out the technique or our way of working out of the window, and we start a new way of working, a new technique or a new strategy. And that's a problem, because when you have bad results, you have to double look learn and look at your assumptions. Why didn't this work? What went wrong? Which countermeasures can I come up with to improve the results? So I think as an organization, we have problems with learning, but also on team level and on individual level. So if we focus on cost instead of quality from a customer value perspective, if we work with old rusty processes and we have difficulties with learning, that leads to chaos. There's something good about chaos, this chaos, because a lot of our chaos in our organizations is self-inflicted, so we can do something about it. And be sure, if your foundation of your organization, your business that you're running is cracked, a cracked foundation cannot support excellence. So I want to look at 4 mindsets, 4 behaviors that can reduce chaos in your organization. So you can better build innovation, but also continuous improvement, problem solving, agility. So the first one, clarity. Clarity is an important mindset. What do you mean with clarity? I mean to seek unbridled clarity around the direction of your organization, but also what value you deliver and who delivers and supports the delivery of value. And you also have to look at the language you use. As a business leader, do you speak the same language as your nurses? Do you speak the same language as your sanitary staff or your medical staff? It's very important to be clear about it. So one of the important mindset to reduce chaos is clarity. Clarity about a lot of things. The second important thing is about focus. And I don't mean focusing on winning, because that is the quickest way to lose. Most successful companies focus on long term. Now, this is about happiness in life, and that depends not only in having a focus or goal, but in having the discipline. The third one you see on this picture. Besides focus, you have discipline to stay focused on the goal. And if I mention focus, I had a nice quotation from Steve Jobs. Focus is about saying no to 1,000 things to make sure we don't get on the wrong track. It's only by saying no that you can concentrate on the things that are really important. So you have to choose. You have to choose as a leader. You have to choose as a manager on which projects do we want to work. And it's hard. And you need discipline. Discipline provides people with rules to live their lives efficiently and effectively. And discipline creates habits, and habits make routines, and routines become who you are daily. Daily at your family, but also daily at your business. Today plus today plus today is your life, is your business. The habits and daily disciplines you create will eventually determine who you become as a business. So 4 different types. The last one is about engagement. If you want to reduce chaos and stimulate learning and improve your processes and have the good incentives, you have to focus on engagement. And the importance of employee engagement can be overstated. Employee engagement has been proven to reduce staff turnover, improve productivity and efficiency, and retain customers at a higher rate and make more profits. Most importantly, engaged employees are happier, both at work and in their lives. When you are engaged, it infuses everything you do with purpose, energy, and enthusiasm. And from the literature, there are 3 engagement drivers. Connection. So the staff, the nurses, the people, the management has to connect to the mission. has to connect to the people within the organization, has to connect to the customers, the patients. Also, control is an important engagement driver. You have to give your staff members, you have to involve them in decision making, and that influence their work life. And last but not least, creativity, full use of talents, capacity, and skills. So, in conclusion, there are 4 mindsets and behaviors that can reduce chaos, so you can build on innovation, continuous improvement, and problem solving. So I hope you had enjoyed my short presentation. We looked at understanding the innovation imperative. How can you turn an idea into a solution? There are different types of innovation. We looked at why innovation is so challenging. It requires a different culture, learning opportunities, feel safe enough to dare, saying to your boss, I don't know. I showed you a few examples from the work floor on our nursing departments, and I ended with 4 habits, mindset that reduce chaos so you can build for innovation and problem solving. Thank you very much. I give the word to Dr. Angelina.
Thank you, Dr. Kjeld. Before we move on to the next speaker, a reminder to the audience, if you have any questions, please click on the Q&A icon in your Zoom control panel and submit them for the panel discussion session later on. For our next talk, we have Associate Professor Genedine Lim from the Singapore Institute of Technology. As the pioneering Program Director of Nursing at SIT, Dr. Lim has worked closely with the healthcare industry and national nursing leaders to establish SIT as an institution that provides post-registration nursing programs to potential nurse leaders of Singapore. During Singapore's fight against SARS in 2003, Dr. Lim was heavily involved. Subsequent to this, she represented Singapore's Ministry of Health in discussions on infection control on the Western Pacific region of the World Health Organization, and in the International Association for Professionals of Infection Control and Epidemiology. Dr. Lim brings a wealth of experience in both the hospital and national levels of Singapore's healthcare system. Today, she will be sharing with us on an innovation project by SIT nursing students where they applied an Eclectic innovation model to support SIT's university-wide efforts in the prevention and control of COVID-19. Dr. Lim, please.
Thank you, Angelina. Thank you for our friends from the Netherlands, as well as from Singapore. So it's my pleasure to share with you what we do in SIT in preparing the students in nursing to take the leadership role in the various healthcare systems in the future. Okay. So I thought in preparing the curriculum for our students, when we prepare them to do an innovation project, we have an interdisciplinary approach. We teach them about health economics. A key emphasis was made today about the importance of considering resource consumption as well as the value we create. We also teach them about data analytics to make sure that the decisions that are made are data-driven, both in defining the problem as well as in measuring the value created by the innovation and quality improvement. We have seen different designs presented by earlier guest speaker from the Netherlands on how the nurses can actually develop products that will be helpful in creating value. Okay? Nursing and healthcare being clinical, we have to then base our design and decision making in terms of quality improvement based on evidence. So we teach them about evidence-based practice. And as we have noticed, a lot of discussions about vaccination in Singapore, but the important thing that has been emphasized from the Prime Minister all the way to the operations manager of the different hospitals is the importance of workflow. Okay? So we teach them about how they implement evidence into real practice using link thinking, both its principles and its tools, and how they create learning organization. So one of our previous speakers mentioned about double loop learning. So we teach our students reflective skills on how to analyze the situation that they have recently been involved in terms of quality improvement and innovation, and what could have they done differently to improve further in the next project. So,
Genedine Lim, sorry, could we, it's a bit muffled. Would you be able to speak louder, please?
Okay, today we have done a lot of projects. Is that better? Okay. Today, this is still, I have put my microphone. Back, Angelina. Okay.
Is that better?
Yes.
Okay, so to date, SIT is the youngest university of the Republic of Singapore. So for those of you from the Netherlands, we are very young. So to date, we have 4 intakes of students taking this module in innovation in our nursing program. And we have about 263 students that have worked very closely with 11 institutions from the ILTC sector. Some of those who are our partners are here today, so thank you very much for working with us in educating our future nurse leaders of Singapore. Okay, they have done about 41 clinical and operational projects to address operational and clinical problems. And there has been very good development. We have been able to work with one of our nursing homes, and the students have actually won the first inaugural, what we call Maple Tree Challenge, a collaboration between SIT and Maple Tree to recognize excellent innovation coming from the students. Where we're doing some projects with 11 organizations when COVID-19 came to Singapore. So there was a elevation of the alert into DORSCON Orange, which in Singapore means I need to pull my students away from the healthcare institutions and bring them back to SIT for infection control. So while I used to go down during that period of work with the institutions and with the students to the respective nursing home, which is your photo on the left, during COVID-19, I have to pull them back to SIT. And as you can see, the students have their mask on, okay? And I'm very thankful for the 11 organizations that we work with, because we have to literally do our quality improvement remotely. So thank you again to the 11 organizations, okay? So what I want to share with you today is that we have been doing projects for 4 years, and we have been using the different tools of lean thinking and design thinking, underpinned with data analytics, evidence-based practice, to be able, and health economics, to bring solutions to real problems presented by our 11 partners. Then we were struck that we do have to do that within SIT itself. So one of our partner organization would not be able to, at that time, cannot partner with us because they were busy with prevention and control within their organization. And so we did one project on school health nursing for the students that we need to pull back to SIT. So this is the project that I'm going to share with you today. So they were challenged to do a surveillance and prevention and control program to make sure that our students in SIT are protected from COVID-19. So we used the plan, do, check, act, the Schuhart PDCA cycle, and lean thinking and principles to come up with a solution. Their client is the vice president of SIT, who was charged with the responsibility to make that the whole SIT campuses within our main campus and or our satellite campuses is going to be safe, both for the staff, the students, and visitors to the university. So applying Schuhart cycle and the different interdisciplinary concepts, the students look at surveillance, prevention, and control with a view to improve. So we look at primary prevention, okay, secondary prevention and tertiary prevention, but primarily in secondary prevention. Should any of the students, primarily in primary and secondary prevention. Primary, in the case that to make sure that no students get infected, but should an infection happen, how do we then detect and to diagnose early and then refer them to our relevant hospital? Okay. So they did employ data analytics because lean thinking involves information-driven definition of a problem as well as solutioning. So based on their data, they have mapped out the flowchart that was based on guidelines from the Ministry of Health. And so from guidelines, how it is implemented by the Singapore Institute of Technology, and look at opportunities for improvement. So those are your yellow highlighted portions of the map on the left. And thereafter, they have improved the process. That is your process on the right. So I'm not showing much of the detail, but more of the principle on how you can use lean thinking and data analytics to then improve the process. So as our earlier speakers have highlighted, including Dr. Au and our colleagues from the Netherlands, is that before you move on to automation, you have to optimize the process and look at areas for improvement. So that's what the students did. And they came up with 2 strategies for primary prevention. And they have came up also with an additional 8 strategy for secondary prevention. I will not highlight everything, but most of about 2 or 3 of them that have been since implemented. The others are implemented, but just to highlight a few examples in the interest of time. Okay, so because we are catering to the students of the Singapore Institute of Technology, and they are in 6 campuses across the island, our main tool that we have that the students have leveraged in terms of public health education is the learning management system for the students. So all the alerts in terms of monitoring, surveillance, as well as actions they need to take into consideration and implement should there be any infection have been incorporated into the learning management system. Okay. So if you look at our workflow, okay, that is how the students identify the alert, and where's the best place to alert is from their process mapping. Okay. And thereafter, apart from the alert, okay, is the use of infrared thermometer. In the early months of COVID-19, we didn't have it. So the traditional form of taking temperature, literally taking a thermometer, has been asked to be the methodology to take temperature and thereafter report it into this system. Now, given the students' recommendation and the development and technology, the university now used this technology for both surveillance as well as reporting the temperature automatically. This improved the workflow because as a professor during this time, the early months of COVID-19, lessons have to be delayed, okay, for purposes of temperature monitoring and recording and taking the attendance. Having this technology in place, we don't have to do that anymore as professor. And as the student and faculty and staff enters the university, everything is captured and everything is then deposited to our electronic repository. Okay. Interestingly, because we are a young university, we are currently in a temporary campus, and we are in the process of designing our future campus in Punggol campus. So this was also an opportunity for the student to look at the design of how the campus would be in the future so that it is going to be foolproof as well as ready for any future pandemic in the future. Okay, so what were our key learning points? Okay, so when you look at quality improvement, while you look at the specific innovation of the students, when you zoom out, it's actually takes a very strong leadership. And that is similar to whether it was in the SIT project or in the projects that the students conducted with our respective partners in the IoT sector. The students have worked very closely with their nursing leaders and also with the chief executive officers and the executive directors of the different institutions. So it highlights the importance of key points. First of all is situational approach to innovation and quality improvement. They have to have the project identified by the CEO and the Director of Nursing so that any project they do will be value driven. Okay. Thereafter, they look at process improvement first, and that's the value map streaming as well as the flow charting that I shared with you. From optimizing the process as well as skills development, okay, the capability development of the staff who are part of this process, okay, because they will implement the workflow, then skills training are then put in place. A key important, therefore, are the leadership behavior and the team behavior as itemized here, okay? And also the skills development that needs to be developed from leadership all the way to every member of the staff that will be involved in this process, as well as supporting this process. Now, there are double look thinking. We need to come back to basic thinking, the mindset and assumptions. In the case of our students, based on what are the directives given from the Ministry of Health, but how is that implemented at SIT? And to challenge some of those assumptions to come up with a more efficient as well as safe process for preventing COVID-19 to spread in SIT. Okay, but a key important point always is to keep an open mind and to always ask, how will we improve or change the way we work and that process? Because without that open mind, the students wouldn't be able to see areas for improvement, and our leadership would not be receptive. So the key ingredients were there, the students that are capable to see what needs to be improvement, and SIT leadership that then were willing to not only support, but implement the proposal from the student. Okay, so this is the last of my slide, and I'd like to thank all of you for your participation today. And so this is this project that has been developed for SIT by the students have actually been covered by the media in terms of how they have helped their co-students be prevented from COVID-19. I thank you very much, and I look forward to discussing with you at the panel. Okay. Back to you, Angelina.
Thank you, Dr. Lim. Next up, we have Mr. Hamyon Dresen, the CEO of UMC Expert, a knowledge transfer agency that connects top-notch researchers and scientific institutes. The mission of UMC Expert is to create value by facilitating the realization of long-term international partnerships between Dutch innovative and knowledge-rich partners and their peers abroad. Mr. Dresen has been helping organizations in Asia and Europe since 2014. Before that, he was a member of the board at one of the academic hospitals in the Netherlands. Mr. Dresen has an eye for the key innovations that can help healthcare organizations in dealing with the challenges of aging populations, staff shortages, and budgetary pressures. Today, Mr. Dresen will present several proven innovations that can tackle the challenges that COVID-19 has presented us with. Mr. Dresen, please.
Thank you, Angelina, and thank you so much for inviting me for this very interesting webinar. Really enjoying listening to all the very interesting presentations. Can you hear me well? Is the quality of the audio, is that okay?
Very good, Hamyon, thank you.
Good. I would like to run through this agenda with you. First, a brief introduction. Then I want to share with you how the Dutch healthcare system works in very basic steps, which is needed to appreciate the innovation I would like to share with you and why it is such a promising direction we are taking. So the innovation itself will be shared with you after describing the way the system in the Netherlands works. And then another very interesting, I think very interesting domain we will tackle is the different phases in the rollout of this innovation, because an innovation will only be valuable when you really apply it in the system. And we end with a conclusion. Now, to start with an introduction, first, let me see. Yeah, there it is. There's a small delay in the the moving of the slides. First, it's good to understand that there's really a long history of knowledge sharing between our countries. Already in the 60s, this started. So more than 60 years ago, we valued the concept of sharing ideas and know-how between our countries. And this resulted in important companies like Philips from the Netherlands establishing their regional headquarters in Singapore for Asia. It resulted in a lot of trade between our countries. So I think if we look at the import and the export value between our countries, the list of other countries, we mutually are in each other's top 20. So I think we have a lot of things in common. We have a lot of history in understanding the value of knowledge sharing. And in this webinar, we continue with this in knowledge sharing in the healthcare domain. Now, the reasons for applying innovation, I think Kjeld showed a beautiful graph in his slides where he showed that the financial part seems to be more important than the quality part, where he rightfully addressed that both should be handled at the same time. So innovations that we will share today with you, we will try to show you that they both address the need for improving the financial setting in the healthcare sector, as well as improving on the quality of care provided. I think this item is not country specific. I think this is an item that holds true in the healthcare sector in any country worldwide. So how can we maintain the affordability of the healthcare sector, knowing that the number of patients due to demographics will rise, and at the same time improve on the quality of care delivered. Now, the innovation that we will see in this presentation that was unrelated to COVID, but the pandemic that struck us all did really give a boost to implementing this innovation. And now also in the process part, in the rollout phase, I will address this. But before we go into details there, let's first take a look at how the Dutch healthcare system works. Well, first, the setting in the Netherlands, it's a small country like Singapore. We have 17.5 million inhabitants. And by law, everyone has a healthcare insurance. So there's no financial problem for anyone to get care when needed. The 17.5 million inhabitants are roughly, this is a rough figure by the way, they live in 8 million households. Well, to get access to the healthcare sector, you're not allowed to go to the hospital yourself, except for the emergency department. So in normal setting, the first step, if you need healthcare, you go to your family doctor, your general practitioner. And the general practitioner functions as a kind of gatekeeper to the rest of the system. And this is important to secure that the right care is being orchestrated at the right spot at the right time. We call this this gatekeeper function, the general practitioner, the first tier in our healthcare system. Then the second tier is general hospital. So if the general practitioner, the family doctor, is not able to help you, then the general practitioner is the one that will refer you to a general hospital where you will be diagnosed and treated further. Then there are roughly 80 general hospitals in the Netherlands. If they cannot cure you, if they are not able to help you, then only them are able to refer you to a university hospital, the third tier for top referral care. And for example, Kjeld, working for Erasmus University Medical Center, is one of the 8 university medical centers in the Netherlands. So this system works well for decades already. And it's good to understand that there's a different cost structure involved in each of these tiers. As you can imagine, the cheapest tier by far is the general practitioner tier. Then general hospitals, due to all the investments they have had to make, and all the skilled staff they have had to hire, the cost price of treatment in a general hospital, obviously, as long as you can compare that, is higher than at the first tier. And the same holds true for the third tier. So the third tier, again, is much more expensive. So to keep the system affordable, there's a movement presently run by the present and the previous governments to try to move where it's possible and where it is in line with the quality of care needed, to try to secure that the right patient is treated at the right tier at the right moment. So the transition presently taking place in our healthcare system is where patients are unnecessarily treated in a too high level tier, it should be organized in such a way that they will be treated in the right tier. This is a very important transition in our healthcare system, and innovations are important to make this happen. And later on, we will see an example of this. Then the general practitioner also is more complex than I'm describing to you now, but for the sake of this presentation, it works well. General practitioner also gives access to nursing homes. So, and in the Netherlands, we have about 115,000 clients getting care in a nursing home. So they are really getting care in a bedside in a nursing home. But many of these nursing home organizations are also responsible for home care, so providing care at home. And the same holds true here, that in the transition of healthcare to keep the care affordable, there's a transition to try to move where it's possible and fitting the quality of care needed. We try to deliver the care at home of the patient, of the client, as much as possible. So these two transitions are important to understand and to appreciate the coming innovation that I will share with you. Now, as mentioned before, we have 8 academic medical centers in the Netherlands, or really now we have 7. So because 2 of the academic centers in Amsterdam merged. And one of these academic centers is in Leiden. It's connected to the oldest university in the Netherlands. It was established in 1575. And the main activities of all 7 or 8 academic hospitals is to provide top referral patient care, research leading to innovations, what we call valorization, so to create value for society as an outcome of the research, and to train and teach doctors and specialized nurses as a medical school and a medical faculty connected to the university. So on the domain of research leading to innovations, Leiden developed a very interesting innovation, and that was based on the idea fitting in the transition of trying to deliver the care in a tier as low as possible, is to develop a telemedicine monitor for chronic diseases, for patients with chronic diseases. And they have now, they've called this concept the box. And they have now some 5 years experience in running this innovation. And since it's a research institute as well, they also adopted research on the implementation of this box concept. And they have a lot of evidence how in practice the results work out from implementing this innovation. Now, the box basically consists of a few items, and next slide we'll see some photos of this. First, it is a box containing devices to measure aspects of the patient. We will go into more detail later on. Then these measurements done by the patient at home will be received at the patient monitor dashboard at the premises of the hospital, where it's being monitored by professional staff. So there's also an infrastructure, a software infrastructure that combines the measurements taken at home and the reading of the outcome of these measurements at the monitor at the hospital. Then implementing this, obviously you need to adapt your processes, which has an impact on the protocols and the guidelines, the roles and the responsibilities of all the actors. And furthermore, a new type of department had to be installed at the Leiden University Medical Center, and it was kind of a customer support center, both for supporting the patients while implementing this new concept at home, as well as providing this monitoring function at the hospital for all the patients using this box concept at home. Now, this started about 5 years ago for cardiac patients. And the reason for Leiden to develop this concept is to, as a research center, to take its responsibility in providing answers for the need for transition of the healthcare sector by limiting the usage of expensive hospital capacity, beds, wards, at the wards, and to at the same time improve the quality of care, the important aspect that Kjeld also mentioned. As said, this was implemented 5 years ago, and implementing this, as I've covered very briefly in this presentation, it needs adaptation of the processes, and lean thinking is really helpful in providing this. Now, the box with this photo, you will see how for the cardio box, so for cardiac patients, it consists of a lot of devices, basically. There's a body scale analyzer, so you can measure your weight every day. There's a thermometer, so measuring your temperature. There's an oxygen saturation device, measuring your oxygen level in your blood, but also your pulse rate. There's an ECG device. There are basically 2 ECG devices, not in the same box, but there are 2 different types of boxes that can be implemented. And there's this blood pressure monitor. And all these devices are capable of sending the outcomes of the measurements via internet, via Wi-Fi connection to the monitor in the hospital. And obviously they're very important. There are manuals inside the box delivered at home, and the manuals have been written in a way that people with low education can really understand it. So they also took an effort in accessibility of the knowledge needed to be able to implement this concept. And the service center at the Leiden University Medical Center was remotely available to address questions while implementing these devices. Now, this is the setting where it all took place. On the left part of the slide, you will see the home setting. On the right part, you will see the hospital setting. And in the middle, you will see you will notice the infrastructure needed to connect both. On the left side, again, you see this is in Dutch, but you probably will understand what's taking place here. The different steps that the patients need to take. So they measure their blood pressure, their weight, their temperature, etc. And this is sent via internet to the electronic patient data file, and twice a week for the cardiac patients, these data are being checked by a professional nurse, a specialized nurse at the hospital. One of the outcomes of this process was that so far, before implementing the box, patients needed to visit the cardiologist, so the specialized doctor, 4 times a year on a pre-scheduled basis. And they've brought it back to 2 times a year, plus 2 video consults of the cardiologist. But much more important, because the number of measurements is very high frequent, sometimes 3 times a day, depending on the setting of the patient. Now there's, instead of 4 moments in a year where there's connection between the doctor and the patient, now a connection between the doctor and the patient will take place if the measurements provided on a high frequency level show a need to. So the patient is in much safer position due to all these measurements and the control by the hospital on these measurements than previously, when there was only a 4 times a year checkup with the doctor. As evidence has showed, the quality of care has improved, as just described, by the high frequency of the measurements done by the patient. There's a very interesting change in attitude of the patients by being so highly involved in its own for its own setting, and patients understand much better by having implemented and using this concept the importance of changing their lifestyle. So they are much more aware of their role and their responsibility in getting better. Due to that, the communication between the doctor and the patient, which is again 4 times a year, but now 2 times a year physically and 2 times a year with a video link, is much more mature and much more effective, because the patient basically is much better educated on its own setting due to the implementation and the usage of the box concept. The cost of the hospital have been dramatically reduced on this small item. You must understand, you will not notice it in the big figures of the hospital yet, but if you zoom in on this segment of patients, it really has reduced the cost structure, and it created a higher level of happiness and appreciation at the patient side. Because the patient felt much more safe, taken much more serious, etc. Now, this box concept, with 5 years of experience, was, when COVID struck the Netherlands March last year, so about roughly a year ago, it took Leiden University Medical Centers less than a month to implement the COVID box, based on all the experience done, created by the cardio box. And this is in healthcare, at least in the Netherlands, but I think this is an issue worldwide. This speed of implementing an innovation is unmatched. It has not been seen before. And similar to the results of the cardio box, with now 11 months of experience with the COVID box, similar advantages have been accomplished by the cardio box. And the cardio box consists, it's a limited version of the cardiac box. The COVID box is a limited version of the cardiac box, and it contains a blood pressure meter, thermometer, and an oxygen saturation meter. And what it provides to patients that are not in a state that they need hospitalization immediately, but the doctors are not sure on how quickly the situation of the patient could deteriorate. And by 3 measurements a day with these 3 devices, the monitoring in the hospital can very quickly address patients who deteriorate quickly and get them to the hospital where they need care in the hospital. So for the patients, it's a very safe solution, but because they know that when it's needed, they will be hospitalized. For the hospital, it's very good because they can reserve the scarce capacity of beds only for the patients that really need it. Now, Putting this back in the setting of the three-tier system in the Netherlands, left you will see the home, then the family with the general practitioner in the first tier, the second tier, the general hospital, and below you see the nursing home and the home care organization, and to the right you will see the top referral university hospital care. What it basically does in the first phase of this rollout is that it was invented at the Leiden University Hospital, and it was provided only to the patients of this hospital, so patients that were already under treatment in the third tier. And that makes sense because it was a development that was constructed at Leiden University Medical Center. It needed changes in procedures, changes in processes, changes in roles and responsibilities. And you can only manage that when you have full control of all these assets. So it made a lot of sense in the first phase to roll out first the cardiac box, but then later on very quickly the COVID box in the domain of Leiden University Medical Center with its own patients where it had full control. Then in the second phase, and this is good to remember, Leiden not only invented it and implemented it, but also ran research based on the data coming out of this implementation. Now, in the second phase of this rollout, the Leiden University Medical Center also asked the general practitioners, the family doctors in its catchment area to participate in this domain, because the organizational strain of doing this, running this solution for its patients was big for a third tier, very expensive system. And it would have been much more focused and much cheaper if the general practitioner could fill in its role. So general practitioners in the catchment area of the Leiden University Medical Centers were participating in the rollout of this COVID box in a coordinated way together with the Leiden University Medical Center. Then in the third phase of the rollout, when the solution had proved itself, the Leiden University Medical Center, together with the general practitioners, were looking for a solution where the Leiden University Medical Center, being very expensive, was not needed anymore. So the general practitioners found the Marente nursing home care organization willing to participate in the solution by providing all the implementation support. And this resulted in this third phase in the next setting where Leiden is kind of out of the equation, but still receives the data coming out of the solution for research purposes. The general practitioner now is in the lead and decides which patients will get the COVID box, and Marente nursing home provides all the operations. And I will describe this in the following slides. When the general practitioner wants a COVID box to be provided to one of its patients, it will give a signal to the Marente organization to send the COVID box to this particular patient. That is step one. And here in this photo, you will see that the COVID box has been altered. It has been simplified. It's not a box anymore. It's a hygienic pocket. And the content of these devices is also cheaper than the first solution that was created by Leiden University Medical Center. Here you see the blood pressure meter, the oxygen saturation meter, the thermometer, and you see an iPad. This is new, and I will go into detail in the following slides on that. And again, a manual, a simple manual. Now, all these devices for this part of the solution are not connected to internet via Wi-Fi. So the patient need to they measure their setting 3 times a day, and they need to make notes of the outcomes of these settings 3 times a day. And then each morning before 11 o'clock, the Marente Operations Center takes proactive contact with the patients via video link. That's why the iPad at the box concept is needed at the home site of the patient site. And the Marente Operation Center writes down, checks the outcomes of the measurements, and knows when it needs to involve the general practitioner for the patient, or the patient is still stable and needs no additional attention by the general practitioner. And this is done before 11 o'clock, because if action is needed, then that same day the general practitioner is still able to contact the patient and to take action there. And this solution was easy to implement because Marente operated already a video link infrastructure with its home care patients. So the infrastructure was available, and the staff of Marente was already used to running an operation like this. And when the patient does not need the devices anymore, the box anymore, then there's also a solution with cleaning material to get all the devices back, to clean them. This is also properly described in the processes. Now, what we see here is through the different phases of the rollout is basically that we implement with this innovation in a successful way the need for transition in our healthcare system to where it started with expensive setting in the third tier system. It has moved over to the cheapest part, the first tier. That is now, with all the help also supported by Marente Nursing Home organization, is very able to take over this role that originated in the research domain of Leiden. Now, the future is very promising in this aspect, because Leiden is continuing developing more boxes for more types of patients. So there will be a pregnancy box, there will be an ortho box, there will be a diabetes box, etc. You can see this on the left-hand side. All these boxes will address issues of the need for increasing quality of care, more involvement of the patients, better understanding of the patients, why lifestyle matters, lowering the cost price, and reducing the strain on scarce assets and capacities, because this movement is not only driven by the need for keeping the healthcare system affordable, so that's a financial part, but also because in some areas there's a high scarcity of professional staff. So it's not only cost, it's also the ability to provide the services given the limited number of available professionals in the healthcare system. And by implementing these boxes, you fill in the need for transition, which basically is to provide the right care at the right time, at the right location, which, as we've seen in the previous example, also needs a more coordinated approach between the different actors in the healthcare chain, like the Leiden University Medical Center involving the general practitioners involving the nursing home Marente organization. And this is really difficult to implement, and therefore COVID obviously is a big burden for everyone, societal burden for everyone, but there's also a positive side. It dramatically did speed up these processes of cooperation in the chain and understanding of the need to implement innovations that otherwise would have taken years to accomplish. Now, so the fourth phase in the rollout of the boxes, partly are we grateful in between brackets for COVID, is that we now have hands-on experience in the value chain, in the healthcare chain, to implement what it takes to implement the COVID box, and we will benefit from this experience by implementing all the other boxes that are being developed by Leiden in the future. So the conclusion of this presentation, this is my last slide, is this innovation, which is evidence-based, based on this evidence is coming out of research being done by Leiden. The cost is reduced, the quality of care has improved, but also the quality of labor has improved. The staff at Marente and the general practitioners are very happy with this additional responsibility in their daily lives as healthcare providers. The patients are very happy with it. They feel they are more safe. They are educated at the same time. It also addresses the big psychological health burden on patients, because if you feel more safe and more in control, there's less strain on the psychological impact of the pandemic. And what it does, it optimizes the utilization of scarce resources. Well, this is basically what I would like to share with you. This solution, we think, is very well implemented, can be implemented very well in any healthcare system in the world. So if there's interest and need from Singapore, then Leiden University Medical Center is very happy to share their experiences with you. Thank you so much.
Thank you, Mr. Duthen, for the interesting sharing on the box concept. Ladies and gentlemen, we have now come to the panel discussion segment. Audience, if you have any questions, please feel free to submit them via the Q&A button on the Zoom control panel now. I will now hand over the time to our moderator, Mr. Arthur Poh, who will facilitate the panel discussion. Mr. Poh, please.
Thank you, Dr. Angie. Welcome to the panel discussion. I know we are running a little out of time. I'll do my best to answer, to have the panelists answer all your questions, or most of them, all right? But not to worry, we will certainly put those questions up on the website, and we will send the web link to you via your registered email. All right, coming back to the panel discussion, it is really my pleasure to be your moderator today. I would like to encourage participants to put up your questions in the Q&A chat. Doesn't matter if it is not addressed today. I will make sure that we will put it up on the website in a week. Well, you can find the question and answer chat located in your Zoom control panel. Right. We have already some questions that were provided to us in the course of registration. Maybe I will hold that back, as I noticed that there are already questions in the Q&A chat. If you don't mind, I can see a contribution from KP Young. KP Young shared this. Hearing from Dr. Au's sharing, it appeared that end-to-end process redesign and technology innovation are critical. And from Dr. Kjeld's sharing, there are many operational innovations that are also possible in the ward and clinical operations as well. KP Young's question is, given the resource constraints, how do you encourage and balance between process, technology, and operational innovations in the organization? Appreciate if our panelists could give a few pointers on that. Maybe Dr. Au or Dr. Kjeld, could I invite you to answer KP Young's question?
Maybe I'll just touch on very quickly. I showed the video to show the whole flow, but I have to be upfront that it is never going to be so straightforward in the sense that we can always do a what I call 100% planning approach to things. But I think the bare minimum must be there. I think first, as an organization, we must have that willingness to ask ourselves, which are the processes that is taking a lot of your resources, and which are the things that your nurses and your care staff are having a lot of problem. I think we must start from that first. Of course, some would say that you can go up to the highest level of strategy. I think it depends. But once you start with this, then what you can do is you map up where are the areas that can provide linkages, or where are the areas that sometimes we say low-hanging fruits that we can work on. So for Kwong, it was very clear. The kitchen element part was very clear in our mind. The transport and the distribution of food has always been on our mind. And so what we therefore need to do is that we started to draw the technology map right at the beginning. What are the things we want to build on? So depending on our resources and time, we then phase things out. And then for each and every innovation that we put it in, we really make an effort to ask the HOD and the person in charge to take the lead, because they will again have to look at the existing processes and then see whether the new things that they bring in, how does it change their processes, whether there are more training that is required. So having said, with an automated wok, it's not straightforward. There's a lot of training at our kitchen side because we need to know what ingredient to throw in. So there's also a little bit of try and error. So I think in a nutshell, from my perspective, I think go simple first. Do some form of mapping of problems. What are the most important things that is troubling? If you can find some level of synergy between two issues, then we take it up and then do a value streaming and redesign the flow, and then see what sort of technology we can go by. I think many of the experts has already shared just now. Sometimes some of the low-hanging fruits, once you identify, you do it and then just do it first. But as an organization, I suspect all of us as CEO or seniors, we need to convince the board. So we therefore need to draw some form of technology mapping and do some long-term planning. And this is the part where maybe sometime we will need some external help. I think that's it. Back to Arthur.
Hey, thanks, Dr. Au. Dr. Kjeld, do you have any points to raise or to add on? Yeah.
I totally agree with Dr. Au. I think you have to start with the process, and technology is just a solution. So you have to understand your problem, and sometimes technology is the solution, but most of the time, in my experience, you start with value stream mapping, you start with going to the Gemba, and a lot of problems we face nowadays, we can solve in better processes and better skills of our doctors and nurses. So, but then again, telemedicine is a good example. We use that. I think before COVID, there was still a great reluctance to develop telemedicine. But the healthcare workforce shifted to telecommuting almost overnight. So there are some examples for technology, but I like to look at the gap on the work floor with the nurses, because there's a lot of work to be done still.
Thank you, Dr. Kjeld. Right, I noticed that there are some lean transformation questions in the chat box, right? And I may need to count on Ham Yung or Stefan to help me with this. Yeah, maybe I should introduce Stefan. Stefan Weiser has been one of our key partners, right, in our Singapore projects. He has been to Singapore many times, helping Kwong Shiu in some of the innovative works. Stefan, maybe could I invite you to share some of your experience on ways to continue lean training, given all that is required for COVID safety precautions. What are your thoughts on this, Stefan?
It's like, sorry. It's like what Dr. Kjeld also mentioned, is it starts with value stream map your processes, so you can see what are your biggest problems. And Dr. Au also mentioned the low-hanging fruits. So also, if you would like to learn more about solving problems, I really suggest to read the book, the new book of Art Smalley. It's about 4 types of problems. And also what you can do, the last one is if you first do your first problem solving, the last one is innovation. And if I look at when I worked in Singapore, I really like that the people are really involved in everything what we are doing. So they are really keen if I ask them to do some homework next time when I was back. they did it. So that was very fine. And I think also at Kwong Shiu, I think we made a very big improvements in the processes. And it was because the people and the nurses are really willing to help us. So that was very, yeah, it was very good.
Right.
So, and if I look at the questions, Arthur, maybe it's also an idea that we have this very good website. You can Google it, or it's planet-lean.com. So planet-lean.com, because I think it's also cover a lot of questions, because there are a lot of case studies on it, and I think people can learn from it. But also come to the SIT training, because I saw some other questions, and I think we are really keen to help all the people.
Thank you, Stefan. Yeah.
Arthur, maybe I can
Dr.
add
Au.
on, since you're talking about lean training.
Yeah, please.
I think the most ideal from an organization point of view is that the people who raise the problem are also the activists to solve the problem. But sometimes we may not necessarily have that most ideal. Then I think it's important for each organization to start training and making sure we have enough activists throughout the organization. So for Kwong Shiu, we have a mixture. We have people who will always be able to raise out issues, but sometimes they may not necessarily be the best person to lead the project. But if they come up with a problem they want to lead, then what do? We make sure they have enough training to know how to tackle the problem, how to approach the problem. And then we also have a scenario whereby we try to institutionalize these activities, whereby we send as many as people as possible whom we have identified for some skill sets, be it design thinking or lean training, so that they are spread across the whole hospital, whether it is in the front line, back line, support, or admin. So together, each organization will have enough people who are willing to raise the issue. We have enough people who are willing to lead the issue to solve the problem. Because if you don't have all this, sometimes it's impossible to always expect always the head of department, or always expect the CEO and the director of nursing to always set up projects. I think if possible, every organization should start planning all this. So of course, I'm sharing a bit of a Goyo. So our partnership with SIT, we have some of this platform where all the nursing home or any other community care sector, you can come in, and then we learn from each other. Back to you, Arthur.
Thank you, Dr. Au. I think that is important, and thank you for the opportunity for SIT to work alongside Kwong Shiu Hospital in this very exciting journey. And for members who are here and who have not worked with us, please feel free to write to us. We will be more than happy to support your organization. From the Q&A chat, I can see there is an easy question for Ham Yung. Ham Yung, there is a question for you on COVID box, whether the COVID box require broadband to work. Example, Wi-Fi, SIM card, or data. Ham Yung?
Yeah, I'll be happy to answer that. The size of the data being transferred 3 times a day is very limited. So there's no need for broadband, not at all. And you can use the G4 or even G3 connection of your smartphone or your regular broadband connection of your home. It all works.
Right. Thanks, Ham Yung. Maybe I should move on to a question on for Genedine. Genedine, would you like to take the question? How should we continue home-based care services, whether it's therapy, nursing, or personal hygiene care, to the vulnerable clients during pandemic period without disruptions? Genedine, would you like to take this?
All right. So indeed, even during pandemic, the needs of our patients will still be there. So, a greater consciousness on your infection control procedures. There are certain guidelines that has been given by the Ministry of Health for those of you who are here in Singapore. I'm not familiar with the guidelines coming from the Netherlands, but you go by the guidelines that has given by the Ministry of Health. Okay. Thank you, Arthur. Yeah.
Right. Yeah, I think it is probably country to country, and we just have to be very sensitive in terms of the guidelines given by the ministry. Right. I'm mindful of the time, and then of course there are more questions than the time to answer them. Maybe just a quick one to end off this panel discussion. I would perhaps invite panelists who are present today to give us a quick response to this question that was sent to us during the webinar registration. Right. The question is this, and maybe each of you can just give me a short response. Right. The question goes like this. Do you see this pandemic changing the way organizations operate going forward? And how would care be redefined after COVID? So I'll repeat the question again. Don't think it is reflected on the question and answer chat. The question goes like this. Do you see this pandemic changing the way organizations operate going forward? And how would care redefine after COVID? Yeah, maybe anyone can take the question. Yes, Ham Yong?
Yep, happy to do so. The positive side of COVID was that there was an immediate sense of urgency throughout the full sector of addressing this disturbance, this disruptive setting. So where it traditionally is very difficult to cooperate and to share information and knowledge and to hand over responsibilities in different parts of the chain, now it was very obvious for everyone that this had to happen. So over the last 12 months, there was an enormous energy for all the different actors in the healthcare chain to cooperate and finding solutions together. And we hope that these months of experiencing this fortunate side of the COVID pandemic will be there tomorrow to continue improving the healthcare chain in the transition needed.
May I pick up on that question, Arthur? Okay.
Yeah, then.
From the so I'm coming from a clinical perspective. And at the same time, the social dimension of the pandemic. From a clinical perspective, what we learn in terms of surveillance, prevention, and control for communicable diseases remains. That technology for diagnosis and treatment may be different because there are new innovation given the new disease condition. I thought what the COVID-19 pandemic has highlighted is a very strong organizational culture to be really united as one, because the break in the chain of infection happens when we don't work together. So this has been very much emphasized in infection control, but more so now. And so the same mindset, because we are very conscious of infection control, can transfer to other things that we do as organization. And that's actually, I'm not selling Koyo, but actually that's the spirit of Lean. You can only solve a process, a problem together, okay? So it will be more emphasized in terms of the need for the skill. Okay, thank you, Arthur.
Thank you, Genedine. Dr. Au?
Yep. Yeah. I'm going to speak squarely on nursing home. I think about 1.5 years ago, before COVID, there was a new infection control manual labeled onto the nursing home. And one of the key messages was MDRO, multiple resistant. And there were many people involved. And they have actually made a decision then that nursing home, by and large, from a risk point of view, actually our elderly are no different from in the community. And therefore, they actually have measures to wind down the infection control measures from acute hospital to COM hall to nursing home. To the extent of saying, for MDRO, you don't have to cohort, standard practice will apply. I think what has changed is that I believe this comment about nursing home as something of a lesser intense infection control has turned 365 degrees, if there's such a degree. So I suspect the script is still being played out. And I'm no expert in this area. I'm not a public health specialist. But stemming from that, actually, from the COVID, you will definitely have a review of nursing home practices that we are evolving. Some will become new normal. Some we may go back to old habit, but it's still an evolving piece. In terms of nursing home staff, is another very big area that has changed. We have more draconian measures applied to staff working in a nursing home than even acute hospital and COMHO. We have even more draconian measures applied to simple things like visitation to nursing home as something more draconian than even acute hospital. So all these are turned upside down. I don't dare to make any comment because all you are expert, neither am I an expert. This will evolve, and I'm not sure how fast we are able to come to the table to say what is the new normal. And to us as nursing home practitioner, all this affects us because it affects our care. It also affects the way we manage our staff. I don't think any of our nursing home provider who is down there is able to give an answer what is going to happen tomorrow and next year. And we can't really plan long term. And a simple thing like housing, we are still struggling. Whether we need to do purpose build, whether we need to change for our staff, foreign staff. Yeah. So my apologies to whoever is listening. The question is too complicated for, at least for me to answer. But all I can say is that the script is still evolving. Yeah, back to you.
Yeah, but I think Dr. Au, thanks for being real. And I think that's absolutely right. Nobody can crystal ball what is to come, right? Maybe Stefan or Dr. Kjeld, would you like to take this last question?
Yes, I think you will see a shift of treatments for patients, I think actually outside hospitals. So in the field of patient care, for example, in oncology, we mobilized last few months to provide solutions to ensure the continuity of treatment with chemotherapy for patients outside our hospital, so they can treat themselves with chemotherapy. Till a few months ago, the patients had to come to the hospital, but now we find a way to give the treatment at their own homes, and it's safe, it works well. So I think that's one example of the shift we see happening during and after COVID.
Thanks, Dr. Kjeld. Stefan?
Yeah, also, especially if you look at the employees of the hospitals before COVID and after, or in the world we are now. So I think people really would like to improve their processes more. So in that case, so that they can help more people. I think for us, in the way we are working, I think this is the biggest difference.
Thank you. Thank you, Stefan. Yeah, before I end, I would like to take the opportunity to thank my panelists for a very frank, very open, very insightful response to some of the very difficult questions, I must say. Some we don't have a perfect answer, right? On this note, I would like to thank Dr. Kjeld, Ham Yong, Stefan. Thank you very much for waking up so early in the morning to do this webinar with us. I cannot stop thanking my friends from Singapore, Professor Genedine and Dr. Au for your support, right? And for everybody in the session today, thank you for staying with us. And I would like to wish our Singapore friends Yuan Xiao Jie Kuai Le, right? For those in Netherlands, today is Chinese Valentine's Day, and it's the last day of the Chinese New Year, a very important event. Right, and to the participants in Netherlands, Blessed Friday. I hope I pronounced this correctly. Vernay Dahe. Have a nice day. Over to you, Anjali. Angie?
Thank you, Arthur. We would now like to invite, sorry, I was on mute, Mr. René Arnold, CEO of Lean Management Institute Netherlands, for the closing remark. René, please.
So thank you, Angelina. Thank you, Arthur. Thanks to the entire panel and all the participants. I think it was a fruitful webinar. We learned that innovations are not just big and driven by technology, but there's a lot of fruitful innovations found on the Gemba by the people doing the work. All they need is a bit of help, support, and especially this pandemic has shown us that it really pushed a lot of innovations. And I hope that also in the coming months and the coming years, these innovations will keep coming, and that some of the solutions we found, like the box, will remain, and we will not go back. But as Dr. Owl already said, I think also some of the things will go back. But in the end, we will still be, we've still improved a lot of the things we've suffered from in the past. So all in all, I think a very helpful, very good way to share all these examples. Appreciate all your time and efforts, and let's continue our cooperation. For those participants that want to learn more, as Stefan already explained, there's some good articles on planet-lean.com, specifically on COVID in healthcare and how Lean can help in this. And also our cooperation with the SIT in delivering Lean programs in the next coming years. So if you have an interest, feel free to contact Angelina or SIT. We're happy to answer your questions. So thanks again. Back to you, Angelina.
Thank you, René. Before we end, we would like to share with the audience that we have 2 exciting programs coming up in the next few months. An exciting Lean Masterclass, where you will learn by playing games, and a longer training program where you will learn by working on an existing company challenge at the workplace. For more information, do feel free to drop us an email stated on the screen. Ladies and gentlemen, we have now come to the end of the Healthcare Innovation webinar. On behalf of SIT, Kwong Hospital, and the Lean Management Institute, we would like to thank you for attending our webinar today. We will be sending out a post-event survey. Do remember to provide us with your valuable feedback for us to have continuous improvement, and also to get an e-copy of the Learning Enterprise book. Thank you, and stay safe and have an awesome weekend ahead.